Hello, thank you for joining me today for our talk on anaemia. My name is Deborah Sumner and I'm the anaemia nurse practitioner in the haematology department here at the University Hospital of North Midlands. I've been a qualified nurse since 2004. My background is originally trauma orthopaedics, followed by orthopaedic pre-assessment, and then moving into general surgery and orthopaedic preams, where I worked very happily for a little over 7 years before leaving my surgical background to work for haematology, in the new post as the anaemia nurse practitioner. My aim is to promote best care and the timely treatment of reversible causes of anaemia, and to prevent and reduce transfusion of red blood cells. I have nurse-led clinics and I assess and review and treat preoperative patients as well as chronic anaemic patients. I'm also responsible for the ongoing training and education across the Trust, which has been trying over the last 2 years. However, my aim is now to promote a trust-wide culture of anaemia management and the use of alternatives to red cell transfusion. So, what is anaemia? Anaemia is the result of either not having enough red blood cells to deliver oxygen around the body, or having red blood cells that are unable to carry enough oxygen. Red blood cells contain a special protein called hemoglobin, or HB, which carries the oxygen around the body, and anaemia is characterised by the low level of hemoglobin. Blood is a complex fluid containing cells and proteins to help our bodies function correctly. These cells include white blood cells, which help fight infection, platelets, which help form clots when we bleed, and red blood cells to carry the oxygen. And oxygen is necessary for all our organs and tissues to convert food to energy. Red blood cells last around 120 days, so the body must constantly make new ones in the bone marrow to replace them. The most common cause of anaemia is low levels of iron in our body, or iron deficiency anaemia. According to the World Health Organization, or WHO, iron deficiency is the top nutritional disorder in the world. Research suggests as many as 80% of people in the world don't have enough iron in their bodies. It also suggests that as many as 30% of people have anaemia due to prolonged iron deficiency. Your body quite simply needs a certain amount of iron to make hemoglobin, which is the substance that moves the oxygen throughout our bodies. We can identify anaemia with a simple full blood count test. The results from these would show you are anaemic for a gentleman over the age of 15, a haemoglobin below 130 grams per litre. For non-pregnant women, 15 years and older, a haemoglobin of less than 120 grams per litre. And for pregnant women, a haemoglobin less than 110 grams per litre throughout their pregnancy would be defined as anaemia. The optimal haemoglobin concentration needs to meet the physiological needs, and this varies by age, sex, smoking habits, and pregnancy status. As the anaemia nurse practitioner working within haematology, patient blood management and the need to reduce our red cell usage across the Trust is part of my role. We need to have a better understanding of patient blood management and the need to embrace this practice, whilst remembering to implement the alternatives to transfusion. Anaemia isn't a disease in itself, but a result of a malfunction somewhere in the body. Therefore, anaemia isn't a haematological condition. It may be due to other conditions from other backgrounds, such as an oncology condition, breast, cardiothoracic, general surgery, gynecology, urology, plastic surgery, orthopaedic, and any other speciality who may be involved in a patient's care and treatment. There are many different types of anaemia as well. So iron deficiency is the most common type of anaemia, which I will focus on today. Vitamin B12 or folate deficiency anemias, these are often dietary related. Thalassemia, an inherited blood disorder where a person produces either no or little haemoglobin. Aplastic anemia, a rare disease in which bone marrow does not produce adequate numbers of new blood cells. Hemolytic anemia is a disorder in which red blood cells are destroyed faster than they can be made. Sickle cell anemia an inherited blood disorder where red blood cells become sickle or crescent shaped, and pernicious anemia. It's an autoimmune condition in which the red blood cells are abnormally formed due to an inability to absorb vitamin B from food. It's worth noting at this time that there is a big difference between vitamin B deficiency and pernicious anemia. In pernicious anemia, the intrinsic factor binds to vitamin B. After attaching, the intrinsic factor and vitamin B travel to the intestine to be absorbed into the bloodstream. If your body doesn't have enough intrinsic factor, this is when you develop pernicious anemia. If a patient has pernicious anemia, please don't test B12 levels, as they will be having regular injection replacements of their vitamin B12, and continuous sampling is not necessary. So what do we look for when patients have anemia, or what signs and symptoms may show us a patient is suffering with anemia? Dizziness is very common, shortness of breath and headaches, chest pains or palpitations with fatigue, pale skin, although this is quite subjective, and pale eye lining, cold hands and feet, general weakness and muscle cramps, reduced immunity, and you may become more prone to infection. Pica, a rare but real eating disorder in which a person eats things not usually considered food. I have had several ladies who were embarrassed to speak to their GPs about their cravings for plasterboard, ice lollies by the bucket load, and coal. My lady used to carry a slate tile from a roof and would need to lick it constantly in private when her anemia was particularly severe. These symptoms independently can seem quite spurious. However, put yourself in the shoes of a 28-year-old lady with 2 young children and a full-time job, desperate to play with her children after work. She brings her children home on the school bus. It's only 2 stops, but she cannot manage the walk home. She provides a meal, helps them bath, and then is completely exhausted. After several months of feeling like this, she finally goes to her GP. She has a haemoglobin of 57 and a ferritin of less than 6. She received a single unit red cell transfusion and a Monifer infusion. 8 weeks later, she contacted me to inform me she did not need to catch the bus anymore, and hadn't even realised till her daughter pointed it out. Her iron deficiency and anemia had been slow and progressive since the birth of her second child, her heavy menstruation, even considering a hysterectomy at such a young age. She's had several Monifer infusions since then and been investigated by gynecology. She now has her quality of life back and can play with her children, as a young mum should. But there are many causes for iron deficiency anemia. I think the 4 main categories for me would be malnutrition, simply not enough iron taken in the diet, low vitamin B12 and low folate. Without the right ingredients to make your blood cells, you're not going to provide your bone marrow with what it needs to make a good quality red blood cell. Malabsorption, things like inflammatory bowel disease, IBS, Crohn's disease and celiac disease. As previously mentioned, blood loss. An obvious one for ladies is our menstruation cycles. Has there been multiple pregnancies in a row? Is there long-term use of non-steroidal anti-inflammatories such as aspirin? Or is there a GI tract loss? Are there ectasies that need banding or varices? Or increased requirements at different times of our life? Pregnancy, providing blood donations, or simply rapid growth? Or is it indeed an accumulation of a few of the same things above? So diagnostic testing for iron deficiency anemia. It's worth noting that you can be iron deficient without anemia. You can suffer with hypoferritinemia, which is simply iron deficiency without anemia. A low iron storage in the form of ferritin, which can manifest itself in all the same symptoms as iron deficiency anemia. The weakness, you may be easily fatigable, you may have depression, palpitation, hair loss. A simple full blood count may show a good haemoglobin, but if you've got the symptoms and the signs of an iron deficiency, a simple ferritin and transferrin saturation test may help. Physical examination. Blood tests to confirm the diagnosis of anemia to help in identifying underlying conditions. On CareFlow, there is a preset blood order for anemia testing. You'll be looking at full blood counts, U&E, ferritin, transferrin saturations. CRPs may be helpful but not necessary. Where your EGFR is less than 60, percentage hyperchromic cells may be helpful. Reticulocyte count, vitamin B12 and folate levels. Of course, further investigations such as GI, upper and lower, may be necessary where the cause is not obvious and unknown. Maybe screening for celiac, or where iron deficiency continues despite a trial of oral iron, it may be further investigations such as myeloma screening is necessary. As previously discussed, your haemoglobin less than 120 grams per litre in a lady, less than 130 grams per litre in a gentleman, less than 110 grams per litre in pregnancy. When assessing ferritin levels, iron deficiency is supported by a ferritin of less than 30 nanograms per mil. This is confirmed as an absolute iron deficiency with a ferritin less than 15 nanograms per mil. Iron deficiency is also likely where a ferritin is less than 100 nanograms per mil and a CRP is raised or the transferrin saturation is less than 20%. In patients with established chronic kidney disease, iron deficiency is supported by a percentage hyperchromic red cells of greater than 6%. In patients with heart failure, iron deficiency is supported by a ferritin of less than 300 nanograms per mil and a transferrin saturation of less than 20%. In patients with a ferritin greater than 100, but transferrin saturation is less than 20%, it likely indicates a degree of impaired iron mobilisation, such as anemia of chronic kidney disease or anemia of inflammation. And with these patients, it's really important to ensure the optimal management of their underlying disease is achieved. Some patients may benefit from iron therapy, but that will very much be on an individual patient-to-patient basis. As with your CRP, ferritin is an acute phase protein. Therefore, if you have an active infection, maybe a flare-up of rheumatoid arthritis, this may show that the ferritin is not as accurate as it would usually be in a patient without an acute phase reaction, active infection, or a flare-up of an existing condition or disease. Once you have identified the reason for the anemia, it's time to treat the patient. So many times do we see a patient has been under investigation under numerous specialities as they have been referred in with anemia and anemia symptoms, yet no treatment had been initiated. Mild iron deficiency can be self-managed with a healthy diet and additional supplements. Treatment in severe cases depends on the cause for anemia. Oral iron supplementation should be tried first in most cases. A trial of oral iron, preferably a high-dose oral iron such as ferrous sulfate, 200 milligrams once daily. Recent evidence shows that alternate day dosing is just as well absorbed as daily. Oral iron should preferably be taken first thing in the morning on an empty stomach, with a glass of fresh orange juice or a vitamin C supplement to aid absorption. Tannins, calcium tablets or containing products, PPIs such as omeprazole and esomeprazole, will inhibit the absorption of your iron supplementation. Therefore, should be avoided for at least an hour after taking your iron medication. If patient complains that the iron medication makes them feel a little nauseous, then you can suggest it's taken at bedtime, and therefore any nausea feeling shouldn't be so problematic during the night. They should continue their oral iron for 3 to 6 months following normalisation of their haemoglobin and their mean cell volume and mean cell haemoglobin to ensure that their iron stores are replenished. And once iron replete, or plenty of iron on board, consider ongoing prophylaxis in people with ongoing risk of iron deficiencies such as heavy menstrual bleeding, and take into account people's lifestyle choices. Is somebody currently on a plant-based diet? No red meat? Are they vegetarian? Are they vegan? Are they perhaps of Jehovah's Witness faith and are waiting for a surgical procedure? In which case, increasing iron stores preoperatively will help them recover and heal postoperatively without the need or use of red cell or red cell products. Also take into account if the patient is waiting for a surgical intervention, if it is major blood loss surgery. A list of these can be found in policy C03 on the internet. It is advised to increase iron stores to greater than 100 preoperatively. Therefore, recognising and diagnosing an iron deficiency anemia as early on in their pathway so this can be effectively treated with oral iron is paramount. To evaluate the response of oral iron medication commenced, you should check a full blood count and a ferritin level 4 to 6 weeks post-commencement of treatment to evaluate response. Haemoglobin should improve at approximately 10 grams a week if there's no significant ongoing blood loss. A lack of response to oral iron will be defined as a haemoglobin increase of less than 20 grams per litre after about 4 weeks of treatment. After iron stores are replenished, the recommendation is to monitor your full blood count and ferritin every 3 months for a year and then annually thereafter, or of course if symptoms return. Where oral iron is poorly tolerated or ineffective, then intravenous iron may be indicated. Intravenous iron should be offered to patients with laboratory evidence of iron deficiency where the oral iron is assessed as ineffective or inappropriate. Intravenous iron forms a part of the patient blood management strategy to optimise patients' outcomes and avoid unnecessary red cell transfusion. In our trust, we use Monifer, unless currently you are a renal patient or under the Shine Clinic at County. Intravenous iron is suitable for adults over 18 years old, and it needs to be calculated using the patient's haemoglobin and body weight. You should always ensure you have a body mass index, as well as this changes the dosing schedule if it is greater than 30. Doses of up to 20 milligrams per kilogram can be given in one administration. That's up to 2,000 milligrams if required by that patient. It can be given in pregnancy, however, intravenous iron should not be used in the first trimester of pregnancy. Verbal consent should be obtained prospectively and documented in the medical note. We should ensure that we have provided our patients with the information leaflet on intravenous iron, which is available on our intranet. Efficacy monitoring should take place 4 to 6 weeks post-dosing with a full blood count and ferritin blood sampling. Red cell transfusion does have its place in anaemia, but please remember, if it is deemed to be necessary, remember we use a restrictive policy in this trust rather than a liberal policy for transfusing single red cells. 1 unit of single red blood cells should be provided, and then monitoring of the full blood count post each dose to see if subsequent doses are actually required. In summary, I think it's fair to say that nothing is ever black and white. Some results for iron deficiency, folate deficiency, B12 deficiency, pernicious anemia may be obvious and easy to see. Other results may be more difficult to interpret depending on the patient's history, current status, and lifestyle choices. But it is fair to say that anemia is everybody's problem and everybody's responsibility. Anemia affects men, women and children and is prevalent in such a large proportion of our population. Globally, anemia affects 1.62 billion people, which corresponds to nearly 25% of our population. Therefore, anemia is common and can be and is associated with poor outcomes for patients, whether it is in their general lives, whether they are post-illness, or whether they are pre- or post-operatively. Early identification and treatment of anemia may reduce the need for red cell transfusion and enrich people's lives. Be that person that treats that anemia. Take an active look at the full blood counts and the general pictures of your patients and friends and family and yourself. Trust guidelines are available on the intranet under B for blood and blood products, then under Iron Therapy to Support Tools. In this section you will find plenty of information on iron deficiency and anemias, hypersensitivity reactions to intravenous iron. There is a management flowchart should you need this. Their patient information leaflet on iron in your diet, oral iron, intravenous iron are all available to be printed here. This is also where you will find the prescription for Monifer, which is a stand-alone prescription to be filled in on both sides and sent to pharmacy when you are ordering your Monifer drug. If I can be of any further help or assistance, or can offer any further training face-to-face or via Teams, please do not hesitate to contact me directly via email at deborah.sumner@uhnm, via Bleep, or via extension number 72576. Thank you for your time.